Welcome everybody to the Health Guider channel, where today we cover behavioral change. When it comes to the management of chronic health conditions like diabetes, cholesterol, and high blood pressure, it's all about lifestyle change. It's all about changing your habits. But you and I both know how hard that can be. So today, I hope to offer you 4 pieces of valuable information. Number 1, the best attitude a patient can have when embarking on change, and that's of patience and the willingness to try again. Number 2, the best attitude a healthcare provider can have when encouraging their patients to change, and that's of empathy and being their teammate. Number 3, Dr. Bucher, our guest, will go over the self-determination theory and how you can use its components to maximize success. Number 4, Dr. Bucher and I will model a fictitious patient-provider interaction and how we can use the learnings from the podcast to facilitate the patient to quit smoking. If you're new to this channel, please hit subscribe and like, and if you have any feedback, leave a comment. I really hope you learn a lot from this podcast. Welcome everybody to Health Guider, a channel that is dedicated to empowering patients to navigate their healthcare. And this is, of course, in collaboration with their healthcare providers. And we have a very, very special guest today, Dr. Amy Bucher. Dr. Amy Bucher has come to us after attaining her Bachelor of Arts in Harvard University, her Master of Arts and PhD at the University of Michigan in Ann Arbor. She currently works for MadPow, a consulting agency in Boston. And she has had a wealth of knowledge and experience in behavioral change products at Johnson & Johnson and CVS. Is that correct, Amy?
That is all correct.
Okay, and I really, really appreciate you coming today because I want to introduce this book that has provided me so much benefit in so many areas of my life. So welcome, Amy.
Thank you so much. I'm really excited to be talking to you today.
Amy, why are all the bad behaviors, all the habits that we know we shouldn't, so easy and so fun, and the ones that are good for us are just sometimes boring and hard? Why?
I had a mentor who used to say, I know we'll talk a little bit about self-determination theory and this idea of basic psychological needs that, we do things because they fulfill these basic psychological needs. But I had a mentor who always said that the missing basic psychological need is pleasure. And so many bad behaviors really do provide pleasure, whether it's the taste of a donut or the buzz of nicotine if you're a smoker. Those really do hit the pleasure centers. I think part of the challenge too is those kinds of quote unquote bad behaviors, they deliver an immediate response. Your body is wired to react to those sorts of things, the fatty food or the drug that's in the tobacco. Whereas some of the good behaviors, it takes time to acclimate to experiencing the pleasure that can be part of them. I think exercise is a great example where starting a new exercise habit is actually really painful. Like if you've never run before and you go on your first run, you are going to hurt. And you're probably going to feel kind of bad mentally too, because you'll realize that you're not very good at it. It's hard to take the time and keep doing it over and over and over until you get to the point where you start to feel really good and refreshed and energized afterwards. And, part of the challenge that is before me as a person who tries to help people change behavior is to try to figure out how can I tune people into some of those positive changes, the positive effects of the good behaviors earlier so that they can kind of, feel the pleasure sooner. And also, how do I help them connect it to a higher order purpose so that they can kind of power through the unpleasant part of it? But yeah, man, we are at a disadvantage because we really are wired for some bad stuff.
Yeah, it's a cruel joke. I mean, so have you found, what are your best techniques to find that pleasure sweet spot?
Well, one thing that we worked a lot with at Johnson & Johnson that I've taken away with me is to pay attention to your energy levels, because that's something that is really quickly affected by physical activity. Even just getting up and taking a quick walk, 2-3 minutes, it noticeably changes your energy level. And so if we can get people to pay attention to that, that's a really quick benefit that most people can appreciate.
Okay.
So that's one that I look to. And then, with food, which is another one that comes up really frequently with kind of any health behavior. A big thing that I encourage is trying to find healthy foods that you really enjoy.
Mhm.
Healthy food is not necessarily cardboard tasting. There are tons of delicious recipes for things that are nutritional or lower calorie or lower fat or whatever your particular dietary needs are. And it's worth taking the effort to find those, because then you can actually enjoy that meal and not feel like you're making as much of a sacrifice. So it's things like that. Like how do you make that immediate short-term behavior feel a little bit better?
Okay. Now that you've spent all these years studying and designing for behavioral change, what do you think healthcare providers are missing in understanding this?
So I think what they're missing is actually the same thing that experts in any field are missing, which is that as your knowledge grows, as you gain this education and experience, and you really understand what the optimal path is, it becomes hard to understand what it's like not to have that information. There's an empathy gap that develops, and this is despite people's compassion and their desire to do the right thing. I certainly experienced it as well as a behavior scientist, but what I wish that doctors would remember is that the answers that seem really clear to them are not clear to their patients. That patients are navigating this, need to change in the midst of all of the other things that are going on with their lives, and they are going to make mistakes. They are going to need to course correct, and it's not as easy as just providing them with the right thing to do. It's really more about coaching and about
Okay.
trying to help people arrive at the way to implement this way of behaving that works for their lives.
Okay. So let's say a very common situation that's occurring across clinics and hospitals. A patient has just been diagnosed with diabetes, and we naturally go to, well, you're going to have to make some lifestyle changes. How would a provider who has that empathy, how would they at least start the conversation with a patient?
So I would recommend starting by having that patient tell you about what their home life is like. Tell me who's living at home with you. Tell me a little bit about what your meal times are like. Who's cooking? Are you ordering food? Who's eating together? That's a huge dynamic actually with diabetes and dietary change that I've seen a lot in various projects across my career, where you have somebody who's diagnosed as pre-diabetic or type 2 diabetic, and they're counseled to change their diets. And a barrier that they encounter is either that they don't control the food in the household. So there's actually another person who needs to get involved and be coached in what the right sorts of things to prepare are, or the person is in charge of cooking for the household but feels unable to make the changes because they're imposing them on other people. So, okay, I can eat that way, but I can't make my spouse and my children eat this food. That's not
Hmm.
what they want to eat. Another thing that comes up often is a cultural mismatch. So if people, their cultural cuisine is not particularly friendly to the dietary recommendations for diabetes or whatever condition they have, there's a gap between, you can say, okay, you can't eat these things anymore, but then the solution that's provided to them doesn't really fit. Like, okay, well, what do I prepare then? I did some work recently out in California where there are a lot of people who are of, various Latin heritages, and we were talking to them about dietary recommendations in food. And one person said, I'll never forget, they're like, I got a recipe that recommended I substitute artichokes for something else, and I have never seen an artichoke in my life. Like, I do not know what to do with an artichoke.
Yep.
There's a deeper conversation that you can have where you can really start to understand, like, well, okay, what do you eat? What would be an appropriate substitution? Let me help you make this more realistic for your life and your needs. And that, I think, sometimes missing with that cursive expertise. Like, here's the
Yeah.
menu of things that you should do.
Yeah. I think two words that you use in your book are boosters and blockers. And one of the things that perhaps I took away, or would like to share with other providers is when you are initiating that conversation, spend some time in diagnosing the boosters and the blockers, the barriers and the facilitators of behavioral change. Is that correct?
Yeah, absolutely. And I mean, just to keep on the food example, a booster would be if you have somebody who loves to cook, who really enjoys making food and is interested in trying new recipes and new things. Like, that's something you can work with as a provider.
Absolutely.
You can really get that person maybe interested in trying some new things. Where a blocker might be the idea that they are preparing food for a family of people who perhaps have preset ideas about what an acceptable meal looks like.
Yep.
That's then something that you would have to work with that person to overcome.
Okay. And what do you wish patients knew more about behavioral change?
Well, similar to providers, I wish that patients understood that it's not supposed to be easy. I think patients understand that it's not easy because you try it and you maybe fail or don't quite succeed. But knowing that that's okay, having some self-compassion around it, and also being willing to try again and try differently. Because what I see happening sometimes is people expect, like, okay, I have this recipe for behavior change, I'm going to try it. And when they fail, they feel like, well, that wasn't for me. I tried, it didn't work, that's it. And instead, what I'd really like to see them do is to go back to that recipe and say, all right, which pieces of this should I adjust so
Hmm.
that it might work better for me? How do I try again a little bit differently and again until I get just that right mix of ingredients that fits what I need and what works for my context? I think there's, we just set up really high expectations for people, and especially because they see the success stories, right? It's survivor bias.
Hmm.
They see the people who've come out the other side and they've made the changes and they've seen the results, and they don't necessarily see all of the struggles that happened behind the scenes to get there.
Hmm.
So I'd really like to normalize this idea that failure, or maybe I keep saying not quite succeeding because typically it's not a total failure. It's like some things work and some things don't, but helping people to understand that that's normal and that is actually progress. So I guess progress over perfection, if I had to pick a cliche to describe what I wish patients knew.
Okay. And I think from what I've learned in the last 5 minutes, one of the most powerful things the patient and provider relationship can foster is, hey, this is going to be hard. You're going to fall a couple times. We're going to be patient and we're just going to keep trying. Is that an accurate statement? I think, would that
Yeah,
be the best case scenario?
I think so. And also, I think implicit in the way you phrased it, and I really like this, is a sense of we're teammates. We're in this together. I'm an ally for you as you work with this, as opposed to I'm an authority figure who's telling you what you have to do, and you'll
Mm.
disappoint me if you don't succeed.
Yeah. I mean, I anytime I start a conversation with a patient, I tell them flat out, I'm addicted to potato chips. And I've been trying to kick the habit for a long time, but I keep going back. And I don't know if that at least provides some sort of compassion, empathy that, I'm right there with you. I know how hard this is.
Yeah, and to the point too, I one thing that I have kind of a pet peeve about is scapegoating a particular food or a particular behavior that's quote unquote unhealthy, because these things can be part of an overall lifestyle. They have a place. It's okay to
Yeah.
eat potato chips as a snack. We all deserve snacks sometimes.
Or a meal
Nobody,
sometimes.
yeah, or a meal, but it happens. And potato chips per se are not evil. They
Yeah.
they have their place in a healthy
Yeah.
diet and a healthy lifestyle.
Yeah.
And that gets again at this progress over perfection. You shouldn't be eating potato chips for every single meal, but if once in a while that's what you really want and you're going to enjoy them and savor them, absolutely, like, have the potato chips, and that is okay.
Yeah. It all goes back to this is going to be a long path. You're going to have patience, but what will help with the patience is finding ways to derive pleasure from this process as well. Uh,
Yes.
so your book is based, or you use the self-determination theory to frame this book and then
Mhm.
move forward. Can you very briefly describe self-determination theory?
Sure. A lot of people are familiar with some of the very basics of the self-determination theory of motivation because it's DC and Ryan's theory of motivation. And so what most people have been exposed to, like in an introductory psychology course, is the idea of extrinsic motivation and intrinsic
Mhm,
motivation. So
mhm,
that some sources of motivation come from outside yourself and some come from inside yourself. The more detailed view of self-determination theory is that what motivates people, what we want to think about, is not just how much motivation they have, but it's where that motivation comes from. And there are several different types of motivation that we can order on a continuum, from the most extrinsic, which
mhm,
actually would be like a doctor telling you you absolutely have to do this thing. that's
mhm,
that's an extrinsic
mhm,
motivator, to the most intrinsic, which is that something is purely pleasurable, you just enjoy it. So that's
mhm,
maybe eating the potato chips.
mhm, mhm,
There's a lot in between, though, and in between is really where most behavior change works, because, especially as you said with your intro question, healthy behavior, most of those behaviors are not intrinsically motivating on their own the first time you do them. Maybe eventually, like once you become comfortable with exercise, that can be something that's really pleasurable. So instead, what we're thinking about are these other sorts of, we call them autonomous sources of motivation, because they're controlled by you, not by something external to you. It's really about what your goals are And that's your big G goals, the things that you care about in your life. So things like, being part of your family and really enjoying those people who are part of your family,
Mm-hmm.
or your career or your community. It's about your identity and the things that you value about the type of person you are. So if you're someone who's really independent or adventurous or courageous, those sorts of things are motivators. And the more that we can align specific behaviors with those things, the more interested you will be in taking those behaviors. So that's a big piece of self-determination theory, and why it's so important to really understand what drives people. And then the other piece that I alluded to before is that to create an experience that people want to engage in, it should support their basic psychological needs.
Mm-hmm.
And that's jargon, like that's right from the theory, the BPNs.
Mm-hmm.
But there are three of them, and the research has shown that they're pretty universal. Like the research has been done cross-culturally and across all different types of demographic cross sections of society. And it consistently shows that people need to have autonomy, so the ability to make meaningful decisions for themselves. They need to have a feeling of competence, so a sense of learning and growing as they interact with the world. There's some kind of effect of their actions.
Mm-hmm.
And then relatedness. People need to feel connected to other people or to something bigger than themselves. So the more that we can build those three things into an experience, whether it's an app or even, a conversation or a plan for behavior change, the more likely we are to get people to engage with that over the long term.
So how can providers fit this into their clinic visits? So, sometimes we have 15, maybe 20 minutes, and where should we start in regards to, so let me give you an example. Um, you have, again, the diabetic patient, and I just diagnosed them with diabetes, and I know that they love deli meats, takeaway food, and microwave foods, right? So, but I'm trying to facilitate autonomy. So I'm trying to persuade them to perhaps choosing this habit to change. And then when I'm trying to figure out, well, is their motivation intrinsic or extrinsic? I just ask them, hey, how motivated are you to change this habit? And if I get a sense of hemming and hawing, how do I change that person's seemingly extrinsic motivation to be more autonomous? Uh, yeah.
So one thing, this is really hard to hear, but I've taken it to heart, and the research shows that this is pretty true. It's you don't really motivate other people.
Mm-hmm.
So what your role is to connect them with motivation they already have,
Okay.
and find ways to connect the behavior changes that you're asking for to that pre-existing motivation. So I'd say one of the questions you want to ask is not, how motivated are you, but tell me about something you're looking forward to. What's important to you in the next 5-10 years? Like,
Oh, okay.
and actually I would just say, tell me about something you're looking forward to, because that's
Okay.
going to give you as a clinician some insight and some idea of what people really value. If they say something like a vacation or, something with their family, like that starts to tell you
Mm-hmm.
something about what
Mm-hmm.
motivates them. And then in the case of diabetes, of course, you can start to talk about, well, I think that you'll really be in much better shape to enjoy that if we can help get some of
Okay.
your symptoms under control, or if we can make some changes now so that you're
Yeah.
really healthy for that thing in the future.
Yeah.
In terms of the food, one trick that I've seen that I really like that taps into this sense of autonomy, and I use a version of this in program design as well. So it's not really like these foods cannot make up the bulk of a person's diet if they want to control their symptoms of diabetes. Like that's a scientific fact. But they may have a place as a treat or a
Mm-hmm.
cheat.
Mm-hmm.
And so it's reframing the choice, not do you want to eat these things or not, but tell me when you want to have your deli meat as a treat. Like, is
Okay.
this something maybe you want to do once a week for lunch? Is it something that you prefer to, I don't know, have a dinner out at a restaurant once a week? But
Mm-hmm.
reframe the choice. So it's no longer, do you want to eat it or not? That's not on the table,
Okay.
because that just can't be.
Okay.
But where there is choice, really elevating that and making it the centerpiece of the conversation so that the person feels like, oh, I do get to have some say in what this experience is like for me.
Okay. Okay. I understand. Personalizing the behavior change for them. And
Mm.
so it is my prediction in 5 to 10 years, given the time constraints that physicians have with their patients, that in addition to prescribing medications, they will be prescribing healthcare apps to help facilitate those lifestyle changes in between clinic visits. What do you think of that?
I completely agree. And in fact, it's starting to happen.
Okay.
So, digital therapeutics is an emerging field, and there's a small handful of digital behavior change apps that have been FDA approved. And they're prescribed. They are actually prescribed
Oh,
by
wow.
providers. The only way
Mm.
you can gain access to them is through prescription. So far, I believe there's one for diabetes, and I
Uh-huh.
know that there are a few. I don't know if they're fully approved yet or if they're in process, but for substance use disorder,
Hmm.
so more on the behavioral health side. But I think that we're going to see more and more of that trend, especially as there's more of an emphasis on building a clinical evidence base for some of these, some of these apps. Because as you've probably seen in the space, there's a mix of people with a clinical background and then people who are more on the consumer design side who are building behavior change support apps. And so correspondingly, as you might expect, you see a mix of really engaging and fun design, but maybe not as much clinical background,
Yeah.
and ones that are really clinically solid, but perhaps not as fun or engaging to use.
Yeah.
So I think you're right. We're going to see more prescribable apps. I think that we'll see the prescribable apps become a little bit less medicalized as well. So right now they're kind of, heavily clinical.
Hmm.
And I think we'll start to see more of the commercial designers getting involved in those like I think we'll see a merging of those two groups that I described, the clinicians and the designers.
Okay. And what do you think some of the barriers will be for physicians to adopt it? I think you mentioned FDA approval, so that would be really big. But when I look around at the culture of, say, academic medicine or even private practice medicine, nobody's really having these conversations about using apps to help patients.
Yeah, I think part of it is just physicians have information overload. Every time that I have done a project where I've talked to physicians about, introducing a new service or a program for their patients, they're very supportive of the idea of it. Like they recognize that there's value in these tools and they want to make them available, but they're just so busy and they're working in these electronic medical record systems that already demand a lot of attention. There's a lot of clicking and
Yeah.
recording and
Yeah.
I mean, one barrier that I've encountered that seems very specific, but it's super common, is that Epic, which is one of the most common electronic medical record systems, it doesn't integrate well with other software.
Yeah.
And every Epic integration in a health system or a hospital is a little bit different. So it's really hard to build something that just plug and play with Epic.
Yeah.
You think about the implementation of these sorts of things, and that becomes a huge barrier. And I think also just the fact that there are so many apps out there right now, that is a barrier too, because providers don't have the time or in many cases the expertise to sit down and evaluate what's available and make decisions about which ones are best.
Yeah. And so if that happens, so let's say we have this diabetic patient, we've identified that certain dietary changes need to be made. The patient feels autonomous and agrees that, yep, I think I will start reducing the intake of this, and that. And we've come up with a path forward that seems pleasant for the patient and seems hopeful for the provider. You mentioned that there are thousands of apps. Now, okay, you might have a provider that has a greatest hits of apps that they use, they feel comfortable with, and they've prescribed. But let's say you just have a simple conversation with perhaps an app might help you, and the patient then leaves the clinic. The patient goes to these app stores and comes across 1,000 apps, all for diet. Where should they even start? How can they validate whether this will work for me? That's a really big question, really tough. But if you could give us some sort of kind of a guiding light.
Yeah, and I will say one thing I've seen several examples of, and to my knowledge, none of them has really been too successful, are organizations that have tried to create a directory of apps, basically going in and doing this evaluation, an expert evaluation, and then saying, here's the short list of apps that are worth your while. Um, I have found, so one of the things that I did, even in writing my book, I evaluated a lot of apps. I don't know how many, a lot of apps myself, and I had to go find them first. And so I would do Google searches for, behavior change apps, diet apps, sleep apps. And I found that generally the first few Google hits, if you use those sorts of terminology, are fairly decent lists of reputable apps. So I actually think a Google search is not a bad place to start.
Okay.
But then beyond that, I think one of the things that we overlook many times, I mentioned there's that whole clinical validity piece. That's important, right? Let's take sleep. If cognitive behavior therapy for insomnia is a clinically validated approach to improving people's sleep, we know it works. And so I would say, if you're going to try to improve your sleep, let's look for a CBTI app that actually builds that in. Okay, fine. But then beyond that, people differ in what they enjoy. They differ in how often they like to get reminders, how frequently they're willing to interact with an app, whether they prefer to listen to something or read to something. So there's that like next level down of analysis that people need to do to figure out if an app might be right for them. And I would actually love to see, I presented at HIMSS a few years ago on something related to
Right.
this, but I would love to see some kind of checklist or evaluation tool that uses self-determination theory to basically say, does this hit the right level of choice for a particular user? Because we do all have that need, but we vary in how much choice we want.
Yeah.
And, does this give people enough of a sense of progress for that competence need that they feel satisfied with it? And does it provide the right dose of social or normative feedback? Because it's not always about social networking or direct connection, but does it at least make people feel that sense of belonging to the right extent? And I think that needs to be a little bit of an individual evaluation. So that's the piece that right now I feel like is really missing, is some kind of way for a user to look at what's out there and say, all right, yeah, this is clinically valid, but does it meet my style? Does it work with what I like?
Yeah. Okay. So, Amy, I was wondering if for the audience, we could just do a simple mock interview
Sure.
where I guess I, as a physician, will be talking to you about one of the habits that you'd like to change. And then we can go through this process. It is just for demonstration. There should be no medical advice taken from this. And we could just, you give us feedback on perhaps this might be more effective when I see patients or not. Does that sound reasonable?
That sounds great.
My favorite patients for several years now. You have done marathons upon marathons. You have lost 200 pounds. We've gone through a lot of behavioral changes. But Amy, you still break my heart. You're a smoker. Tell me, Amy, what are you looking forward to in the future?
Well, I've done all these marathons, but I've thought maybe an Ironman might be a fun thing to conquer. That's kind of the next big athletic endeavor. And, it is frustrating that I'm so active, but I feel like I just can't break through and run a faster time.
Okay. Do you think that maybe your lung capacity is preventing you from reaching those times?
I mean, probably, probably.
So, Amy, I bug you every time, but I'm just doing my job. What can I do to help facilitate you stopping smoking?
We've talked about this. I want to quit. I know that it's not healthy, and I know that some people find it gross, and
Mhm,
I hate that I have to go outside all the
mhm,
time and
mhm.
smoke, but it's just so hard. Like, my body really misses it when I try to quit. And frankly, I feel like some of my best friends, that's what we do when we hang out together, and like, I don't want to lose my buddies.
Okay. So it seems like if I understood you, the main blockers or the main barriers to changing this would be one, you seem to have a pretty deep and rewarding social network that happens to smoke as well. Is that correct?
Yeah, yeah, it is. I mean, it's just we grew up together, and that's kind of the way we grew up, and now we're all stuck smoking.
Are there any other barriers apart from the connections that you've built?
Well, like I said, I'm physically addicted to it. When I try to
Mhm.
stop it I feel uncomfortable. I crave it, and that's really hard.
So we have, if I understood right, the main barrier is going to be your friendship. And then if you do have a conversation where either the friends are interested in quitting or you guys, or they support your quitting, then the next step will be managing the withdrawal symptoms. Is that correct?
Yeah, that sounds right. And we haven't really talked about quitting. It's not something that I know if they want to or not.
Okay. Well, would you be interested in having that conversation?
I think, I just don't know how to get it started.
Okay.
I'm a little nervous that I would come across as a goody two shoes, or like I'm judging them, and I'm not judging them. But
Okay.
I've put all this time into training for marathons, and it does feel I feel self-conscious and embarrassed sometimes when I'm getting ready for these races and, I'm stubbing out my cigarette right before I start my run like that. I recognize that that is not what most
Yeah.
people do.
Yeah. Okay, Amy, look, I understand that there's a real social emotional tug to you stopping smoking. If and when you are ready to perhaps even have that conversation with your network, I'm right here. We have plenty of resources on the internet. Becomeanex.org, becomeanex.org will be a good resource. Perhaps when you have some time, just glance over it. It may give you some tools or techniques to bring up that conversation with your social network. But do know that I'm really proud of you. You've done amazing things for your lifestyle. But also know that next time I see you, I'm going to be asking you about smoking again.
Okay, I'll be prepared.
Okay.
I
Well,
hope
thanks.
I won't break your heart next time.
It's okay. It'll mend. So Amy, how was that, and what using the science that you know of, how could that have been better?
Yeah, and I will say that was a little strange for me because I am not actually a smoker. I feel like I want to put that out there
Yeah.
that I'm not. What I really liked actually that you did was, first of all, acknowledging that I might not be ready. I think that's a really important thing. And from reading my book that with any sort of behavior change, I really believe that it's important not to push people before they're ready because they may react really negatively to that and then not approach you
Mm-hmm.
at a time when they may feel more ready. So I'm a big believer in planting the seeds of change and
Mm-hmm.
waiting for the conditions to come about where they can sprout. So I thought that went really well. And I also think recommending a specific resource is really good. There is data on this, but I will say, even from my career, having a physician recommend a resource goes a long way towards getting patients to try it. Years and years ago, when I worked for, so it wasn't even Johnson and Johnson yet; it was Health Media, which is the company that I worked for that Johnson and Johnson acquired. We had a digital health coaching software that we sold to health plans and large health systems. And with one of our clients, they were seeing very low uptake. And so we created for them this little, it looked like a prescription pad, like a little pad of paper. And it had the URL to access the program and all the information they needed to create an account. And the physician would just tear one off the sheet and hand it to the patient with their paperwork at the end of the appointment. And we saw a huge increase in use of the program just from that. So very little work on the part of the physician, but having that person there, that trusted expert who has the relationship, say, I think this might be a good thing for you,
Mm-hmm.
really makes a difference.
Okay. So Amy, I'm going to try and summarize everything that we've learned today. First and foremost, having or facilitating a conversation between the patient and their provider, an empathetic conversation that we all have habits and lifestyle changes that perhaps we want to endeavor, but we have to have a lot of patience and maybe even facilitate like a teamwork relationship. There are apps. There are thousands of apps. They're getting more clinical validation, and some are even being FDA approved. So in time, there may be a lot of conversations between providers and patients about which app would be the best. And the third thing is just the providers bringing up the conversation and giving resources to a patient will far increase the likelihood of change than not. Is that correct?
That all sounds pretty straight on. Yeah.
Okay, perfect, Amy. Well, where can our audience reach out to you?
So I'm on Twitter a lot, more than I probably should be for my own mental health, but you can
Okay.
find me there at Amy B PhD. I also have a website, amybucherphd.com, and I work for MadPow. So madpow.com is a great place to find out about our work there. And, I have my little, there's actually quite a bit of work that I've produced on the MadPow website in our insights section, as well as some of my colleagues who are doing related work. So I'd recommend checking that out too. And then, of course, I have a book,
You
so
have a book.
Engaged, Designing for
Engaged.
Behavior Change.
A wonderful,
Um,
wonderful book.
Thank you. Yeah, I'm excited to have it out. And I was really excited, when you reached out to me, because what I wanted to do with writing the book was to introduce this idea of behavior change and specifically like usable tools to people who might not have that in their toolkit already. So I was so thrilled to hear that you had liked the book and that you were able to use some of it.
Yep, absolutely. Well, thank you, Amy. I really appreciate it. And well, I guess that's it.
All right. Thank you so much.